Good morning, everybody. It's so good to see you all here, and welcome to the 16th Annual Symposium for Parkinson's Disease. I'm happy to see a lot of familiar faces and also some new ones. So it's nice to see us all come together as a community. When you look around, you know that everyone in this room is touched by Parkinson in some way, and it's nice to know that you're not alone in that. And in fact, millions of people in the world have Parkinson's disease, and tens of thousands are diagnosed every year just in the United States alone. So today our goal is to learn a little bit about the directions that treatments are going and what we ought to know to live well in today's world with Parkinson. So if you're not familiar with the format, the first keynote speaker will all be together in this main room, and then we'll split into two tracks so that you can pick which talk is most appealing or useful for you. In one room, we'll talk about exercise in Parkinson's and sleep and why they're important and how they can help. And in the other room, we'll talk about partnering with your medical team and how to make the most of your medical team in managing your Parkinson, followed by wellness and physical therapy in Parkinson's. So right now, I'm going to go ahead and introduce our keynote speaker. We're absolutely delighted and honored to have an international expert, Dr. Tony Lang, coming to us all the way from Canada to speak to you today about Parkinson's. Dr. Lang is the Director of Movement Disorders at the University of Toronto and also the Director of Parkinson Research. He's very well regarded in the field and has written over 100 chapters on Parkinson's and hundreds of articles. So he truly is an expert, and we're so grateful to have him. We're grateful of the support of the Parkinson Foundation and of the Stockdale Lecture Fund and all of you being here, and of our many volunteers who help make this event possible. I also want to finally draw your attention to the last session. Once lunch comes out, we'll have the Ask the Expert panel. So you can write all of your questions on pieces of paper, and they'll be brought to the front so that we can answer as many of them as we can. And that's always one of the funnest parts. So with no further ado, I'd like to introduce Dr. Anthony Lang.
Good morning, everyone. How is everybody? You all awake? Okay, I'll try to keep you that way. So, my job is to sort of try to keep you up to date and tell you what's going on in the field of Parkinson's. And this is going to be a somewhat eclectic lecture. I'm going to cover a whole bunch of different things, and unfortunately, I'll apologize now. I have to leave for a flight at noon to give another talk in New York. And so we'll have some questions, if you'd like, immediately after my talk, and then you can save other questions for the experts later. So we're going to talk about new developments in the field this morning. Okay, so it's very important for doctors now to give you disclosures because we all work with pharmaceutical firms, and you've got to understand that some people can be very biased in their comments. I try not to be. But I do work with companies that are developing some of the treatments that I'm going to talk about, but I will try to remain completely unbiased. Now, this is the book that started it all. This is the book that Dr. James Parkinson's in England, wrote in 1817, believe it or not. So we are about just over 200 years since his original writing. And believe it or not, he described only 6 patients, and 3 of them he only saw on the street. So he only examined 3 patients, and remarkably, he described all of the classical characteristic features. So he was a very observant physician. And 50 years later, a very famous French neurologist by the name of Charcot recognized Parkinson's contributions and named the disease after the doctor that had written it. Now, we actually recognize Parkinson's was probably described in the Bible. It was probably described in ancient Egyptian writings. So Parkinson was really the first one to describe it in so much more detail. But there are individuals that probably had it long before then. When Parkinson described it, this was the Industrial Revolution in the United Kingdom. And so it was thought that maybe because it hadn't been reported or described to any extent prior to that, that the toxins in the environment from the Industrial Revolution must have been a cause. And so there's been a lot of interest in the role of toxins, but we now recognize this was described well before the Industrial Revolution. When doctors teach medical students, we usually use this acronym, TRAP, to describe Parkinson's, and you're all very familiar with many of these features: tremor, rigidity or stiffness in muscles, akinesia or slowness, and many people don't complain of akinesia. When did you go to your doctor and say, my bradykinesia or my akinesia is really driving me crazy? You often say, I'm weak. I can't get the things that I want to do done the way I used to. And it's perceived as weakness, but it really isn't true weakness. And what we call postural disturbances. And the postural disturbances can be a flexed or stoop posture, or it can be disturbances of postural reflexes and falling, for example. Now, we recognize that many of those features, but one of the points that you're going to come away from today is knowing that it's not exclusively this. Many of those features relate to too little of that really critical transmitter you've heard about in the brain, dopamine. And so, again, I don't think you can see it. You see that the red line that comes up? So the dopamine cells they're housed. They live in this black area of the midbrain. The big part of the brain you've all seen the pictures of sit on this stem, brain stem, and at the top of the brain stem, there are these neurons that have pigment. It's a black pigment that is due to the metabolism of dopamine. So they use dopamine as a transmitter. They talk to other nerve cells by manufacturing and releasing dopamine. And so you have too little dopamine because these cells are damaged and are dying. And with too little dopamine, the symptoms that I've mentioned, the tremor, the rigidity, the akinesia, etc., are manifest. So especially in the early years, much of what we see and much of what you experience as part of Parkinson's relates to too little dopamine. And that's why we replace the dopamine in our treatment. Now, one of the really important things, again, you can't see, you see that circular thing with the halo down at the bottom there? That's what we call a Lewy body, L-E-W-Y, and a man by the name of Levy described these in the brain in patients with Parkinson's in the early 1900s, and we now know that those Lewy bodies are made up of a protein, many proteins, but especially an important protein called alpha-synuclein. And alpha-synuclein is a protein that is normally in the brain, has a normal function in the brain, but when it becomes abnormal and it folds abnormal and aggregates and accumulates, we see degeneration of the brain cells. So alpha-synuclein, really important protein, and it's, in simple terms, it goes rogue. This normal protein becomes abnormal, and it contributes to the damage and degeneration of the brain cells. And unfortunately, you can't see a lot of these things, so I'm going to have to describe. From the left side to the right side of the slide represents the progression of Parkinson's. So we now recognize that well before you present to your doctor with a little bit of a tremor or slowness, maybe your walking has slowed down a little bit, long before that, we recognize that alpha-synuclein has gone rogue. It's causing degeneration in brain. You haven't reached a threshold of dopamine abnormality. You need about 60% loss of dopamine, believe it or not, to start to have the tremor and the slowness and everything else. And so, well before you present to your doctor, this disease is established in the brain, and it can cause a number of other symptoms. So we're now talking about what are called prodromal or premotor or preclinical Parkinson's, and that's one of the points I'm going to be making in a few minutes. Then as you come across that slide from left to right, you begin to see the tremor, the rigidity, the slowness. We treat patients, replacing the dopamine, and for a long period of time, patients do very well, and there's often what we call a honeymoon period. They respond well, and often they don't even notice the symptoms of Parkinson's. But unfortunately, the disease is slowly progressing, and so in the later stage, the more advanced stage, we begin to see many symptoms that don't respond terribly well to the dopaminergic treatment, and that really are one of the biggest challenges we have, and we'll talk more about that as we go. Now, really important, you would say, okay, well, I've got a brain disease. I've got Parkinson's disease. I'm told that it's due to too little dopamine in my brain. Believe it or not, there's a lot of argument about where in the body Parkinson's disease begins. And in fact, there's a lot of evidence that it begins not in the brain, but outside the brain. In nerves in the bowel, in nerves in the skin, in nerves in the heart, for example. And so it may not be the central nervous system where this disease initiates. It may be outside in what we call the peripheral nervous system. And that's obviously very relevant because if we want to diagnose Parkinson's at the very earliest stages, and I'll tell you why we want to do that in a minute, it's going to be very important to recognize that if we're waiting for tremor and rigidity and slowness, we've already got 60% dopamine deficiency, right? So we want to diagnose this disease much earlier because the future is trying to prevent the progression and protect the brain from demonstrating these manifestations. So this is a picture that we put in one of the publications we wrote a few years ago, and I'll just highlight them. Again, I apologize, you may not see them very well, but I've outlined the bowel, the heart, so somebody's pointing, thank you. The olfactory system. People with Parkinson's very typically have lost their sense of smell or have an abnormal sense of smell well before they present with the symptoms of Parkinson's. Or the lower brain stem, where we see problems with blood pressure and sleep and a variety of other places. So that's the first question. Where does the disease begin? We think there's a lot of evidence that it begins outside the brain. The next question is, when does it begin? And as I've already told you, it probably begins well before you thought you had Parkinson's disease. And there's some evidence that, again, you can't see very well. There's a lot of evidence, in fact, that it begins many, many years. And it depends on what symptom we're looking at. So people can be constipated for up to 20 years before you actually present with clinical Parkinson's. You can have certain sleep disturbances for 50 years in some cases before you manifest the Parkinson's. So there's very good reason to think this disease is a very, very slowly progressive disorder that's been in your body for a long time before the symptoms are more obvious. And it just depends on what we're looking at as to how long we say it's present in advance. So we now, as I've mentioned, think about what is called often preclinical or premotor. Premotor meaning, obviously, before you develop the slowness and the stiffness, etc. And you can just scan down this list to see some of the ones that there's pretty darn good evidence for. Loss of sense of smell, constipation, sleep problems, mood problems. Depression is not uncommon. Now, when patients have Parkinson's, obviously it's not fun to have Parkinson's. You're told you've got a disease of your brain, and so we see somebody begin to have mood difficulties. So there's probably in some patients a reaction to learning you have Parkinson's and having to live with Parkinson's. So that's reactive depression. But in fact, depression may be a chemical disturbance in the brain as part of the disease process. And you can have depression and anxiety, again, long before you ever knew you had Parkinson's, probably because of the Parkinson's disease in your brain. So olfaction, this is extremely common. Believe it or not, it's as common as tremor at rest in Parkinson's disease. So very, very common symptom. It's usually present when you first arrive at the doctor if it's tested properly. And in fact, unlike many of the other symptoms of Parkinson's, it doesn't seem to change very much over time. So if we measure the severity of your olfactory or smell loss, it really doesn't evolve and change and worsen the way many of the other symptoms do. We don't know why that is. There are many ways of testing olfaction. So the top one is a scratch and sniff card, just like, you get this in the magazines. You scratch it and you smell. And then many smells can be tested. The one on the bottom are what are called sniffing sticks that measure both the type of smell and the intensity of the smell. And then in Toronto, because we're a single-party payer healthcare system, actually I have my fellows test sense of smell this way. It's much cheaper. It's a little less efficient, but it works sometimes. Constipation, very common, and this is the way doctors write up different collective features that are found in multiple articles. So all of the lines from the top down are different articles. Everything to the left of that line that comes down the middle would be no constipation, no evidence of constipation before Parkinson's. Everything to the right is evidence for constipation before Parkinson's. And there's very good evidence that about twice as often as you would expect, people present with constipation. So they're more constipated than the general public. But there's a lot of constipation in the general public, politicians especially, right? So that's not a very reliable test. If we said everybody with constipation is going to get screened for Parkinson's, or everybody that has a loss of sense of smell is going to get screened, there's a lot of other reasons that you lose your sense of smell. Get banged in the head, for example, very common loss. Smoking is a common reason for losing sense of smell. So these are common as a premotor or preclinical feature, but they're not strong enough for us to say, oh yeah, we've got to screen everybody who's lost a sense of smell and constipation. I think we need combinations of these symptoms, and that's in fact what our field is doing. Now, you all go to movement disorder doctors, right? You know what a movement, and you've been told how important it is to see a movement disorder doctor. Well, we're now in a new era of definitions, right? This is movement disorders in a very different, this is bowel movement disorders. And in fact, your movement disorders doctors are getting good at being bowel movement disorder doctors as well. And this is one of the scales, the Bristol stool scale, believe it or not, showing us the different kinds of stools that we rate in patients with bowel problems. Sleep abnormalities. This is a very interesting area. There's something called rapid eye movement behavior disorder. And you all know that when you dream, your eye movement, your eyes flash. And you've probably got dogs, and you've seen the dogs when their eyes are darting around, or your children did this. And the dogs have a little bit of paddling movement in the feet, but for the most part, there is a normal brain ability, a normal brain function, that shuts off your brain's connection to your muscles when you dream. And why would that be? It protects you, right? You have a dream, and you start to fight and run and shout. You're going to jump out of bed. You're going to hit yourself. You're going to hit your spouse. So you become what's called atonic. You lose tone in muscles when you dream. That is a normal physiologic function. But in rapid eye movement behavior disorder, or RBD, you've lost that normal inhibition. So when you dream, your brain still has good active control of your muscles, and you fight, you punch, you shout, you smash the lamp, you hit your spouse. And this is a fairly common feature in Parkinson's disease and may occur many, many years before the development of Parkinson's. And in fact, there are a large group of people in the world that have what's called idiopathic REM behavior disorder, because all they've got is that symptom. They don't have any obvious Parkinson's, but we know if we follow patients long enough, almost 100% of people with that will develop Parkinson's or a related disorder. And this becomes very important because we can predict that these people will develop a neurological, they have a neurological disease. They just haven't manifested the usual things that you would expect for Parkinson's. And that becomes really important because this becomes one of the most reliable predictive factors that is premotor or preclinical. This is a really interesting patient. So we learn, doctors in this field learn a great deal from examining individuals and taking all the information we can gather from single patients. So all of you help us help our understanding of the disease, and therefore hopefully help other people with the disease. And so this was a patient that was studied in Europe, and you see here at the top, again, I apologize for the size, at about the age of 69, this patient had rapid eye movement behavior disorder and nothing more. And all along from the bottom, from the top to the bottom on the far left part of this slide shows all the things they could have, like Parkinson's features, like olfactory loss, like constipation, like mood problems, those things that I told you about, okay? So that's all this guy has. So this patient, as I told you, he was evaluated by a smart group of people who learned and teach us about the disease, and so he was seen about a year later. And one of the ways we have of evaluating the brain and the dopamine, remember the dopamine area is very important in Parkinson's, we have scans, and some of you may have had these scans. These are called dopamine transporter SPECT scans, so DAT scans. Does everybody know about DAT scans? All right, so this is a way of us looking at the dopamine in the brain in a living individual. And you see here at the top, those little blobs, the red, orangey blobs, two sides of the brain. Does everybody see that? Okay. Those, can we go back one? Okay. So this is a normal DAT scan. So the dopamine looks like a comma, and you see these two blurbs or lumps on either side of the brain. Okay. So now the patient, is it working? Great, thank you. So now the patient has a change in the heart innervation. So there's what we call an R to R interval. That's the bottom box. Again, you don't see it there, but there's some change in the cardiogram. Now, don't worry. Although we can measure things in the cardiogram in Parkinson's, that is never symptomatic. So although with very careful evaluation of the heart rhythm we can see changes, you don't have heart blocks, you don't die of changes related to a heart rhythm function, but we can measure it. So this patient now has an abnormality in the cardiogram, and he's had a SPECT scan that shows no abnormality. Now at the age of 74, he has an abnormal SPECT scan. It's become slightly abnormal, and he has subjective loss of sense of smell. Remember, all he had a couple years ago was REM behavior disorder, right? Now, a little bit later, he's complaining of some difficulties with memory, and he's got some constipation, and his SPECT scan is further abnormal. Now, at the age of 76, I believe it is, there is still no signs of Parkinsonism. He's got some additional complaints, a little bit of lightheadedness when he stands up, suggesting that the control of his blood pressure may be a little bit disturbed. Now, many years after he's had REM behavior disorder, he still doesn't have Parkinson's. So what does he have? He's got Parkinson's disease, doesn't he? But this is Parkinson's disease without Parkinson's, right? He's got no slowness, stiffness, tremor. And that's where we're at in our field right now. We're thinking that we should be able to make a diagnosis of Parkinson's without what we would normally think of as Parkinson's. And sure enough, this man donated his brain. Very important for you to know. Brain donation advances our science and our understanding. And you can't take it with you. You can't use your brain after you're finished living. And I always joke with my patients when I talk to them about brain donation, I'm not going to take it before you're finished using it, right? But if you think about brain donation and give this very valuable gift to future patients, it is very, very important. And sure enough, this man knew that and donated his brain, and he had those Lewy bodies that I showed you, and he had loss of the dopamine cells, but there was only a 20 or 30% dopamine cell loss. So the patient hadn't reached, remember the threshold I told you about? He hadn't reached the threshold that we recognize as important to the symptoms of Parkinson's. So you can have Parkinson's without Parkinson's, so to speak. Okay, and this is the way we think of it now. So Parkinson's disease, when we see it in our clinic, is the tip of the iceberg. So this is the iceberg of Parkinson's with the line of the ocean. Below the ocean surface is a lot of stuff that we need to start thinking about and researching and working on hard. And you see that you can have what's called pre-physiologic Parkinson's all the way up to just before you can make a diagnosis. And this slide shows you that in this premotor group that I've been telling you about is the loss of sense of smell, the what we call autonomic dysfunction, the cognitive difficulty sometimes, depression, etc. So we're now thinking of Parkinson's in stages, and there's a very famous neuroanatomist by the name of Heiko Brack who's been emphasizing this for some time, and you may come across that name, Brack, B-R-A-A-K. And he argues that the disease begins in the low brain stem, way down here, and you see up here, I don't know whether you see it terribly well, it doesn't show on that one at all. This is the olfactory complex. So you lose your sense of smell when that's affected, and this is the low brain stem. And so probably the disease is spreading from the bowel and other regions up to the brain and then begins to spread in this way. And so you see the disease gradually spreading up. and only at Braak stages 3 and 4 have you hit the dopamine cells, and now you have symptomatic Parkinson's, and then more overt features as the disease continues to progress. So this is, remember that DAT scan, this is another kind of scan that does the same thing, and the black one on your far left is a normal scan, and you see over the course of this patient's disease, first a loss of the changes on this side. Do you see this side still looks pretty normal? So here's a patient who presents, remember the left side of the brain controls the right side of the body. Parkinson's, for reasons that we don't understand at all, usually begins asymmetrically. And think about it, those of you with Parkinson's in the room, most of you noticed some shake or slowness on one side first. Why that is, we just don't understand. It's a real interesting challenge. But this patient has abnormalities in the left brain, so he or she would have developed symptoms on the right side of the body, but then you see over the course of time, both sides become abnormal. And we would like to prevent patients from coursing through that progression, right? So let's start talking about treatment. We can divide treatment for Parkinson's disease under these 3 general categories. Ideally, when you come to the doctor with Parkinson's, and in a real ideal world, as I've emphasized before, we make the diagnosis even before you presented with your slowness and stiffness. It's at that point we would like to initiate what has been called protective or disease-modifying therapy, something that would slow the disease progression and ideally halt it in its tracks. So that's the first option, protection. The other 2 options or categories would be treating the symptoms, replacing the dopamine, as I've already told you, for example, or restoring the damaged nerve cells. And we'll talk about each of these as we go now. So the sequence of events in Parkinson's then. We don't know the cause of Parkinson's. I could give you a long talk about the theories behind this, but we know there are a number of genes that cause or contribute to Parkinson's disease, but most people don't have a strong family history, but we know genes are very important. They probably combine with environmental factors, but we don't know what the environmental factors are that are important. So you've got the combination of genes and environment. So the old saying is, genes load the gun, environment pulls the trigger. So it's probably a combination of those 2. They combine to cause abnormal cellular mechanisms in the brain and outside the brain that then result in the deposition of that alpha-synuclein protein, the Lewy body. The abnormal cellular changes result in neuronal injury and death of nerve cells, that then cause the dopamine cells, for example, in that black area, the substantia nigra, to be lost, and with that you get symptoms. So you can put the various different treatment components into this kind of schematic, right? We can treat symptoms, symptomatic therapy. We could restore or replace damaged nerve cells, or ideally, we move even further upstream and we protect against the cause and the results of the damaged nerve cells, okay? So let's think about each of those very briefly. So ideally, we protect or interfere with the mechanisms. Now you see this yellow line. This is a hypothetical line of nerve cells in the brain. Let's say they're dopamine cells, but they could be any other region. And with age, we all lose nerve cells, unfortunately. So those of us with a lot of gray hair have a lot fewer nerve cells than those that are younger. But just because you're aging, you don't automatically get Parkinson's. Something else occurred that caused the Parkinson's. And so you now see the trajectory change. So the cells are being lost more rapidly. And once you cross this blue line, you have enough symptoms to make the diagnosis. And then you cross the red line and you've seen a doctor, and the doctor has confirmed that diagnosis. And the blue line is just the symptoms. So remember, you're losing nerve cells, but you've not reached the threshold. Now you've reached the threshold, and the symptoms are gradually getting worse. So cells lost, symptoms worsening. And you've reached, as I told you, that threshold about the red point when the diagnosis can be made. And so you've got this kind of change, and you are progressing over the course of, like that. And you've seen this slide already. So the search for neuroprotection, what we've been doing to find disease-modifying or neuroprotective drugs, has been really quite an effort. And I always liken it to the search for the Holy Grail. So those of you that remember Monty Python, I'm Canadian, so we loved UK humor, but I'm sure that you probably remember Monty Python. So a number of us, I was pretty junior when we started all of this, so I might have been in the back row. But we've been doing an awful lot to try to find neuroprotection, and unfortunately, we haven't found the Holy Grail just yet. And there are many drugs that act in many, many different ways that have been tested. So it's not for want of trying that we've failed. And this is just a slide. You don't need to know the details. This is a long list of drugs that have failed. And we've spent millions and millions of dollars trying to find the Holy Grail, and yet we've failed. Fortunately, to give you a little bit of hope, just because we've got a lot of tombstones doesn't mean we've stopped trying. And this is a slide that shows you all of the drugs that are actually being studied to see whether we can find neuroprotection. And there are various different mechanisms. We're not going through the details today, just to show you that there's a lot of action, there's a lot of activity in this field nowadays. And one of the most exciting areas that a lot of us are hoping for are vaccinations, using antibodies against what? That rogue protein. Antibodies against alpha-synuclein are really actively being studied in what we call phase 2 trials around the world, and we're really hopeful that that's going to be helpful, but if it doesn't, it's going to teach us a lot. And that's the important thing. It's really important also for you to know that participation in clinical trials, participation in clinical research is critical. It's not us trying to get you, it's us and you working together as a team to get answers to try to knock off this terrible disease, right? We've got to look at ourselves, the doctors and the patients and their families, as working together for a common goal. And working together and participating in these kinds of trials is really very important. So what we're trying to do is prevent this movement of the rogue protein and the degenerative disease that we think in many patients is spreading up the brain, and at the very late stages can cause a lot of symptoms just beyond tremor and rigidity and slowness. So let's just predict the future now for this first part of this talk. I think the diagnosis of Parkinson's, from what I've told you today, we're going to be making well in advance of what we do now. It's going to be before you present with your tremor, your rigidity, your slowness. And it's probably going to be possible in many people to make a diagnosis of Parkinson's disease, as I've told you, before anybody has features of Parkinsonism. And so when we're thinking about these protective trials, we're probably going to take people that have a greater risk. For example, they have REM behavior disorder, they have constipation, they've lost their sense of smell, they've got a composite of symptoms, and look at patients with that composite, and hopefully we'll have some marker of the presence of alpha-synuclein, and then we'll take those individuals, we might do a DAT scan or some other scan. Hopefully we're going to have what are called biomarkers, I'm going to mention that in a minute, that will specifically state that you've got the disease present, and these are the people that we're going to be applying neuroprotective therapies, hopefully before they even have any features of Parkinson's. So you see, you've seen this one already. You saw the yellow line coming down. The goal is to initiate treatment here and to change the slope of that line. In an ideal world, we'd stop it and the slope would be exactly the same as original, but maybe it'll just slow it a little bit. And we're going to have to accept varying levels of success here. And you can see if we do that, we will be slowing the development of the symptoms. The blue line changes as well. Ideally then, what we're going to do is take patients who haven't even got any evidence of the dopamine deficiency and perhaps even prevent them from going on to. So you can have Parkinson's disease, and our treatment in an ideal world, and I don't know how long we're away from this, it may be possible to never get the signs of Parkinson's, to know you've got Parkinson's disease, but never develop the tremor, the slowness, etc., if we have successful neuroprotective therapy. Okay, remember I talked to you about the DAT scan? This is another scan that does basically the same thing. This is what's called a Levodopa PET scan. So this is more of a research scan, not widely available, but it's a very good way of looking at dopamine in the brain. DAT scan is the same thing. It looks at the loss of the dopamine cells. No, it's what's called a SPECT scan. It uses radioactive substances. So you have a very small amount of radioactivity, and it goes to those brain areas. And DAT scan is available in the United States now for diagnosis, but most of the time we don't need it. This is the use of these scans for a research purpose. Okay, so now let's go to that second form of treatment, the symptomatic therapy, which usually restores the lost dopamine. In the case of surgery that we'll talk about in a minute, it also alters what we call motor physiology, the cellular activity. Now, one question that we've been struggling with for a very, very long time is when should we start this very potent drug that replaces dopamine, L-Dopa? And there has been a lot of discussion about delaying this. And there was worry, in fact, that Levodopa was toxic to the brain, that it encouraged the degenerative process even more. We know that it is not neurotoxic. So there's very good evidence now that dopamine or Levodopa doesn't damage nerve cells. There's always been this discussion that we should delay it because, it's going to stop working in 5 years. And I want to use my Levodopa when I really need it. And if it's going to stop working, I shouldn't take it in the first few years. That is rubbish. If you read anything about that says that, you tell them, no, that's wrong. I've got patients in my practice who've been using Levodopa for 30 years or more, and they're still responding to Levodopa. The disease evolves, as I'll tell you in a minute. So there are symptoms often seen in later stage Parkinson's that respond less well to Levodopa. But Levodopa still remains very effective for symptoms related to too little dopamine. So we shouldn't think about delaying it because it loses its effects, because that's wrong. This is one of the big reasons that people have been worried about delaying Levodopa, and that is because, as many of you know, Levodopa has what's called motor complications. And we'll talk about that in a minute. And so one of the arguments has always been that instead of using Levodopa, we should use what are called dopamine agonists. Dopamine agonists are ropinirole, pramipexole, those are the two, rotigotine. Those are the three main ones that we have available that you've probably heard of. These are the motor complications. The two general areas that you think about is that people notice that when they take a dose of Levodopa, they get better, but then it's not sustained. And then hours later, they get worse and better when they take it again, and then worse when it wears off, then better when they take it again. So they have a bit of a roller coaster kind of response, what's called the short duration effect of Levodopa. Unfortunately, it is a short-acting drug, and there have been lots of attempts at making it last longer, and I'll mention those in a minute. On top of this variable response, Levodopa causes those abnormal involuntary movements, the dyskinesia. Everybody heard of dyskinesia? And we obviously would prefer not to have the dyskinesia, but in fact, it's a necessary evil with Levodopa. And in fact, the people that get the best responses to Levodopa very frequently have some dyskinesia. But I always point out to patients when they're worried about that is, look at Michael J. Fox. You've seen him on television with dyskinesia for how many years? And what's he doing? He's still working, he's still producing films, he's still doing all sorts of things despite having those dyskinesia. So it is not the worst thing in the world, and in fact, he does very well because he's getting a good response to Levodopa. This is a little study to teach you that we did in Toronto, where we took 3 groups of patients. The first group were just diagnosed and had not been treated yet with Levodopa or any drugs for Parkinson's. The second group were treated but didn't have dyskinesia yet. And the third group had dyskinesia. And we asked them the same questions. We asked them how concerned they were about having dyskinesia and whether they would like us to treat them differently to avoid the dyskinesia. And this shouldn't surprise you, but it really is important to go through it. The first group never had treatment yet, and the second group, a little bit similar, didn't have dyskinesia yet, were really concerned about having dyskinesia. That's the last thing that I want. Don't treat me with that. I've seen those dyskinesia. I just do not want those problems. The last group who had dyskinesia really weren't that concerned about it. Most of them said, you know, they weren't as bad as I was worried about. And in fact, when we asked them, would you want us to delay treatment or change our approach, the first two groups said, yes, do everything you can to avoid the dyskinesia. The third group said, no, I'd prefer to have the benefit that I get from my medicine, and I'm much less concerned about you holding back and delaying and preventing the dyskinesia. So for the most part, dyskinesia are not that big a problem. We don't want them. We have to deal with them, especially in younger patients, but it shouldn't be a reason for you to avoid the best drug we have for Parkinson's. Now, a lot of people say, well, okay, that's fine, but you've got other drugs that will delay the development of dyskinesia, the dopamine agonists. And so I was a part of a large number of studies that actually showed that if you use dopamine agonists early, you do delay dyskinesia. However, they're not as good as levodopa. We know that they don't work as well, and they don't, once you start levodopa, you're not protected from developing dyskinesia, so delaying levodopa doesn't do that much. And there's really little evidence when we follow people who started agonists first that they're any better in the long term. And this is a really neat study that I thought I'd tell you about that brings this home. This was a study done by some smart guys from Italy, and they had a connection with Ghana in sub-Saharan Africa. And so they had a group of Italian patients in their clinic in Italy, and they had these people from Ghana, and they evaluated the time from early symptoms to diagnosis, the time from diagnosis to treatment, the time from treatment to complications, okay? Symptoms to diagnosis, diagnosis to treatment, treatment to complications. And the different colors represent that. So in Italy, again, so here we go. Okay, in Italy, fairly short time that the patients had delay in diagnosis. Now they're treated, and this is the time that they're treated with levodopa without complications. So the blue is good, and here is where they start to wear off and have motor complications. Okay? What happened in Ghana? Ghana, there's a long time before the diagnosis is actually made. The patients are symptomatic, but they're not getting the first world health care, and that's obvious. So they're symptomatic but haven't received treatment. Now they receive treatment, or actually now they're made a diagnosis, but because levodopa isn't as readily available in Africa, there's still a delay before they get the levodopa. Now they get the levodopa, and look at the time that they spent without motor complications. And compare that to what happened in Italy. So the darkest blue, and again, I apologize, this isn't showing very well. Okay, so what does that tell us? It's not that the levodopa is this horrible bad culprit that's causing motor complications. It's that the motor complications correlate much more with the severity of the underlying disease. The longer you delay, and I have this time and time again in my practice. Again, the patients are worried, I want to delay, I don't need levodopa, I'm not happy with taking medications, I want to delay until I absolutely need it. But the longer you delay and the more disabled you are from your Parkinson's because you're delaying, the shorter time you're going to spend once you get the benefit from the drug to the initiation of the motor complications. So it really is important for you to recognize then that it's not the treatment, in fact, it's the disease duration and the severity of the underlying treatment. And so withholding levodopa to delay motor complications is just not justified now. And this slide I actually show to my patients in the clinic fairly regularly when they're continuing to resist initiating treatment. So we can delay those motor complications with dopamine agonists. However, we're now recognizing that these drugs have a lot of complications, and one of the groups of complications we're now seeing with dopamine agonists are what are called impulse control disorders. And I hope your doctors talk to you about these if they're using these drugs. These are still very good drugs, but we have to educate the patients and the families quite a bit because a proportion of patients get pathologic shopping, gambling. I've seen patients lose hundreds and hundreds of $1,000s due to the gambling induced by the drugs, pathologic eating, binge eating, or hypersexuality. And so patients can actually have a combination of these symptoms as well. So these are still useful drugs, but we have to educate our patients and their families and follow people very carefully. These are more common, in fact, in younger patients too. So how should we treat patients when we start? I think there's good reason to use the best drug we have for Parkinson's, levodopa, but maybe there's an argument for combining different drugs. We really need to move away from what has been termed levodopa phobia. And I don't know whether your doctors in some cases or patients and families have developed this worry or concern. We're really spending a lot of time trying to get away from levodopa phobia. It is a magnificent medication for Parkinson's. And it's it's now in generic, so I'm not getting paid to say that, believe me. The advantages of delaying levodopa with dopamine agonists are overshot by the long-term studies and the adverse effects, etc. Okay, so now let's move to other therapies. And the symptomatic therapy, restoring dopamine, ideally should be done. Remember, we've got this roller coaster I pointed out, right? You're going up and down and up and down. That's because we're using a short-acting drug that stimulates the receptors for dopamine in a very non-physiologic way. So normally the brain releases dopamine in a consistent, what we call tonic fashion. It doesn't do this on a regular basis. And so ideally, our treatments will be to replace the more normal continuous stimulation rather than you see the pulses of individual doses of levodopa. So we believe a lot of the complications, the motor complications like dyskinesia and motor fluctuations, relate to this abnormal stimulation. And the system gets primed by the exposure to levodopa in this way. So the question is, can we improve or mimic the physiologic process with new treatments? And this is just a list. You don't need to know the details, but there's a lot of work going on to try to get levodopa to be given in different ways. So we recognize this up and down is not good. We're trying to improve upon that by newer formulations of levodopa. And many of you might be taking Ritari, another formulation of levodopa that combines a short-acting and a long-acting drug, formulation of levodopa. It's not the best way of doing it, but it's a bit of an improvement on what we were doing before. And as you can see here, again, just scanning the list, you don't need to know the details. There are many companies working on different formulations of levodopa that hopefully will last longer. One of our problems is that the way we give levodopa now is very inefficient because we rely on hurdles. And levodopa has to jump multiple hurdles. It's got to be swallowed, it's got to go through your esophagus, it's got to go into your stomach. The stomach has to empty it, and it has to get to the small intestine. The pill has to dissolve. Once it's in the small intestine, it has to get absorbed into your bloodstream, and from the bloodstream, it has to cross the blood-brain barrier and get into your brain. That's a lot of hurdles. So how can we expect taking an oral pill to give you this nice continuous stimulation of dopamine? It's impossible. So we obviously need better ways. And this was one of my patients, just to show you how really unreliable this is. This patient was one of our duodopa patients, so the gastroenterologist was an hour and a half after she took her last dose of levodopa, looking down into her stomach, ready to do a small stoma procedure. And this is the levodopa tablet she had took an hour and a half before. So if you take your levodopa and you say, sometimes it's just like I didn't take it. It didn't work. This is one of the reasons. It may not have dissolved. It may not have moved from the stomach to the small intestine. This is an hour and a half before she took her pill, and there it is. You can almost see the markings on the tablet. It's so undissolved. So it's a very unreliable way of giving levodopa the way we do now. We need better methods of doing it. So there's a lot of different treatments that we're now using for these motor fluctuations, and the details of these slides are not that important. It's to assure you that there are many new therapies and older therapies that we use, some of which are designed to make levodopa last longer, to block its breakdown, for example. We can block enzymes that chew up the levodopa and make it last longer. We can give drugs that enhance the effects of levodopa or work on other transmitters. And so there's a great deal of research and development in this field now. And as you know, and I mentioned duodopa, we can infuse drugs, and the advantage of that is that you do get this nice continuous level of stimulation, but that's more invasive. So we're also thinking, remember I said it's not all just dopamine, the disease goes beyond that, and so there are a number of treatments that are looking at non-dopaminergic therapy. And this slide just shows you, we're looking at adenosine, we're looking at glutamate, we're looking at noradrenaline and serotonin. Again, the details are not important, but there are many systems in the brain beyond dopamine that we're trying to alter with new or novel medications. And again, this field is very active, recognizing that Parkinson's is definitely dopamine, but it's more than just dopamine too, especially as the disease is progressing into other areas. Now, one of the features that I started with that we'll talk about very briefly is remind us that Parkinson's is not only not dopamine exclusively, it's also not just motor. It's not just tremor and slowness and stiffness and walking problems, it's the constipation, it's the problems with your blood pressure, it's the problems with bladder and function. And so we're now in an era where we recognize, and hopefully, and I know for a fact because of how good the group here is, your doctors are talking to you about non-motor features quite regularly. So the whole field of non-motor Parkinson's is very active. I have 2 slides to show you. Again, the details, you can scan them, and a lot of you are going to look at the slide and say, yep, I've seen it, got it, heard about it. So these 2 slides show you a list of non-motor features, from psychiatric and psychological to sleep problems. But what I want to show you, if you just scan the slide, and now I'm going to show you the same slide, and the new markings are those symptoms that we have treatments for. So almost every one of the non-motor symptoms we are directing or sometimes quite capable of treating or at least partially helping by various different management approaches. And so this is why your doctors take a lot of time talking to you. I tell people now, Parkinson's, from my perspective, is the most complicated disease in the world, and it's one that takes the longest time to care for, because if you're doing it right, you should be asking about all of these things. And you guys should be aware of those things and be ready to talk to your doctor about the presence of these things, because many of them are treatable. The next slide, another second list of non-motor symptoms. And again, watch the slide change, showing you the symptoms that are marked that we can treat with various different approaches. And again, the details of what approaches you can ask your doctors about, but it really is very important for us to recognize we have lots of things to offer people with Parkinson's if we take our time and work together. One of the things that we do recognize with respect to these non-motor symptoms that hasn't really been well appreciated is that just like the motor symptoms can go up and down and fluctuate, the non-motor symptoms can do the same. And sometimes the non-motor symptoms are even more bothersome than the motor symptoms. So we sometimes have patients that really don't have a lot of change in their motor, but when their levels of dopamine stimulation are falling, that's when they get anxious or panicky. That's when they get restless and have to move about. There may be a variety of non-motor symptoms that come out, especially when patients, so-called, go off and their stimulation level drops. And this is, again, one of the most important things that we do in talking to you. When you come and tell the doctor that you're depressed or you feel sad or whatever, oh yeah, let's just start an antidepressant. No, it may be that you only feel that way when the levels of stimulation are falling, and it happens a few times a day. And it's the recognition of that then the doctor will treat the fluctuations and may not have to be using a specific antidepressant drug, for example. Okay, now let's move to the next group of approaches to management, and that is the surgical management and the neurorestorative management. So we think of, you saw this slide before that you couldn't read, and remember, everything on the left was early Parkinson's. Everything on the right now is advanced, later stage Parkinson's. And there are a lot of symptoms that unfortunately we don't manage very well. And this is one of our biggest frustrations as doctors that manage Parkinson's. There are a number of symptoms that we struggle with, and we know you struggle with. But there are some symptoms that we need to separate, and those are the motor fluctuations and the non-motor fluctuations. So I try to change this slide to emphasize those things because we have therapies that we now call advanced therapies that may manage these things. So these are in patients, and some of you might be in this category, where you're spending 25% or more of your day experiencing those off symptoms, whether they're motor or non-motor, and sometimes those off symptoms can be very disabling. We can't get you nice and smooth just by adjusting the oral medicine now. That's when we start to think of the advanced therapies. Now, the predictors of advanced therapies. What would be the most important predictors of advanced therapies? 1, 2, 3, the response to levodopa. We don't have advanced therapies that go better than your best response to levodopa. And so this is why, and I know they do it here, your doctors or the nurses in the clinic will, when we're starting to think about advanced therapies, or we're not quite sure whether your complaints really fit into responses to medicine, we observe the response. We get you to come into our clinic, we get you to take a dose, and we watch and follow. We learn the same language. This is very important. I always tell my fellows and the patients and the nurses, I'm not sure what language you talk. Right? When you say, I'm shaky, are you talking about dyskinesia or are you talking about tremor? I'm restless. I don't know, again, whether that's a side effect of medicine or too little medicine. So I need to observe your response. What gets better? How much better does it get? And with that, we educate ourselves, doctors and nurses, but we also educate you and your family, and that's when we know whether you're appropriate for advanced therapies. And this is a list of some of the surgical therapies, and again, we're not going to spend a lot of time on surgery for Parkinson's. You're very fortunate that you work with one of the best surgical programs in the world, with Dr. Oken and all of the colleagues that he has, and so they can teach you a lot more about surgery than I can. This is the brain with the nuclei in the various different parts of the brain, and again, the details are not that important, but I'm just going to build this cartoon to show you the various surgical therapies that have been used in Parkinson's. We can use deep brain stimulation, or DBS, in many brain targets, or we can do what are called lesions. We can burn small holes and damage the abnormal activity in those areas. We can use stimulation of the spinal cord. We can use this new technique, magnetic resonance imaging guided focused ultrasound, that some of you may have heard. It's a way of lesioning the brain but without cutting through the skull. We can use transplants of cells. And initially this was done with adrenal cells, then it became used, fetal cells from normal fetuses, and now there's a lot of interest in maybe using stem cells. We can use other sources of cellular activity, and these are some of them. We can use gene therapy, and we won't go through the details, but there are a variety of different types of gene therapies. And so this is a summary of all of the different surgical approaches. You can see that we've attacked every part of the brain. My neurosurgeon says there isn't a nerve that's safe from a neurosurgeon. And so neurosurgeons attack with good reason, because we have belief that we can improve patients' function. Some of these are trying to replace damaged cells, some of them are trying to make dopamine more effective and efficient, and others are trying to disturb or alter the disturbed motor physiology. In late-stage Parkinson's, as I've mentioned though, so far all of those treatments largely, not exclusively, but largely have at best replicated the best response to levodopa. So here we have, unfortunately, a list of symptoms that are beyond dopamine and that really plague us. This is what we're dealing with in what we call the later stages of Parkinson's, that we need better therapies for. This is why we need the research. This is why we need good groups like the one you have here, working very hard to improve upon the way we manage these symptoms. So where are we headed in the future? I think we're going to make the diagnosis far earlier than we would ever have imagined. We're going to be making the diagnosis of Parkinson's before our patients come to us with tremor, slowness, stiffness. Hopefully we'll have diagnostic markers, or what are called biomarkers, and those will tend to improve upon the success of the diagnosis. I think that we're going to see at what we call the mid stages of Parkinson's, where you start to fluctuate, you start to get dyskinesia. I think with the advances in the newer ways of giving dopamine replacement, something that'll continually stimulate those receptors more physiologically, I think we're going to see a lot of what we're dealing with now, those motor fluctuations and dyskinesia, as a minor issue. I would really predict in the next 10 years, those aren't going to be a big deal anymore. What we really need is the advances in our understanding of how to manage and ideally prevent the later stages of Parkinson's. And so we need novel therapies that will slow the progression of the disease. We need better biomarkers, and let's skip that. One of the things that we recognize now that I lectured about yesterday to the fellows and staff is the fact, and they know this already, that we talk about Parkinson's disease as if it's this single disorder. Everybody in the room here with Parkinson's has the same disease. That's not the case. It's much more appropriate for us now to think Parkinson's diseases. We know that some genes cause specific types of Parkinson's disease. If there are several genes that cause Parkinson's, why is it that we're so reluctant to say that people without a gene have different diseases? So we need to think of what's called heterogeneity. It's not uniform or homogeneous, it's heterogeneous. And if we think about this as a non-uniform disorder, not a single disorder, in fact, I think we're going to see big advances. We're going to see something that's very hot in medicine now applied to cancer and a variety of other diseases. It's called precision medicine. It's not enough. You see all the different colors in the traditional approach here? These are patients with Parkinson's disease. All the blues have one form of Parkinson's, all the greens have another form of Parkinson's, all the reds have a third form of Parkinson's. And there's probably many, many more. So to think that we lump everybody together to try to prevent the progression of Parkinson's with a new experimental agent is probably kind of stupid. It's what we're stuck with right now because we don't know how to divide the forms of Parkinson's adequately yet. And there's a lot of effort to try to learn more and divide them. And so what we're doing is we lump them all together, give them a single drug that we hoped would slow the progression, and that's why we've got all those tombstones in that long table that I showed you earlier. They've failed, but had we just taken the blues, we might have found that 5 or 10% of patients actually had a great effect of the drug. But instead, we've lumped the blues with the reds with the greens. It's all the same disease. And so I think we're moving away from that, and cancer has done this very well. Think of what you know about breast cancer. It's not enough to say, I've got breast cancer, or you diagnose your wife with breast cancer or whatever. They look at the cells under the microscope. Then they characterize the receptors. Then they characterize the genetic predisposition. Are you a BRCA-positive gene carrier or whatever? And once they've got the cancer diagnosed at multiple levels, then they know what anti-cancer therapy to apply to you. And this is the same with lung, colon, breast, etc. Parkinson's, one disease, we're going to give you one drug. That's pretty naive, isn't it? So I think we're going to see a big change so that in the future we're going to be dividing Parkinson's up, and you're going to have Parkinson's type A, Parkinson's type B, Parkinson's type C, and be treated in a different way. And hopefully that's the way we're going to be able to slow the progression successfully. So thanks for your attention. I'll take any questions that you've got. Yeah, so one of the problems that I showed you with the absorption of the drug is that it needs to get into the bloodstream, and there are many hurdles that it has to jump. And in fact, a sublingual formulation of medication overcomes that problem. And so there are treatments developed for nasal insufflation. There's an inhaled form of levodopa coming along. There is a dopamine agonist called apomorphine that can be put under the tongue. So these approaches, they're largely good for what we call rescue therapy. So somebody who's already on the downswing, and they know that if they take their next oral medication, it's going to be 30 to 60 to whatever minute, an hour and a half before their medicine works, or it may not work at all because it sits in the stomach and doesn't get it dissolved. This is the kind of use of those types of formulations. No, the regular levodopa under your tongue won't be absorbed. So what we do is, if you're in that situation, if you're beginning to go down and you know you're going to have to wait for a while, crushing your regular levodopa and taking it with a carbonated beverage will often swoosh it through the stomach faster and get you on sooner. So there's still hope for some brain recovery. It's possible that he's had a fairly significant head injury, and then superimposed on 18 years of Parkinson's is fairly well-established, long-standing Parkinson's, so you know that he's got fairly diffuse Parkinson's in his brain, and it's very much more sensitive to external factors, such as additional injury. This is why when you've had long-standing Parkinson's and you have a urinary tract infection, you don't respond to the urinary tract infection the way you did 15, 20 years ago. The brain is much more sensitive to the toxic effects of having an infection. In the same way, some sort of peripheral injury and the damage that you get from the shake-up in the brain may very well have created the problem. Then you've got, on top of that, the orthopedic recovery from the hip. So be patient. I can't say for sure, but it can take a long time for the situation to improve. Now, one of the problems that I always emphasize to patients is, unfortunately, you've got a progression of disease, right? So you're following that course. Then you fall off a precipice with an acute illness. So you've fallen off that course. It may take a long time to get back on the horse, so to speak, get back to where you would be, but where would you be when you finally get there? Remember, the course is going here, you fall off the precipice. If you got right back, which isn't happening, you'd be back to where you were. It may be you're going to come back here and you're not going to ever reach the point you were before because the nature of the disease was one of progressing still. So I think you just have to be very patient and hope for the best, but it's very hard to predict.
I suffer from very severe gastroparesis, and I've learned this morning that disintegration of the dopa medication is going to be affected by that. Do you have any suggestions for people like me?
Yep, so with that, I think it's very important to recognize that you're going to be more prone to some of the problems that I've talked to you about already, and taking medication in fashions that are dissolved rapidly, different formulations, or as I've said, crush your tablets and take it with carbonated beverage. There are formulations that are getting through the stomach, that are being developed now, that are getting through the stomach faster. And then if all else fails, normally we don't think of this in an early stage of Parkinson's, but if you're really having to wait for hours because the drug isn't being absorbed, then bypassing the stomach, using, for example, a duodenal infusion of levodopa might be a consideration in that situation.
So thank you so much, Dr. Lang, for
you're
joining
welcome.
us.
Thanks, everybody.